All right, everybody, I'm Patrick Smith. I'm a psychologist and biostatistician at Duke University Medical Center, and I'm going to be talking about lung transplantation psychosocial evaluation guidelines. I don't have disclosures that are as directly related to this particular work, although some of this was funded by the Cystic Fibrosis Foundation, so I should mention that. Most of my other funding has come from the NIH, and then a little bit from foundation funding from Boomer Esiason Foundation and the CFF, and the Duke Transplant Center. Okay, so by way of framing most of what I'm going to be talking about, most of the things that we evaluate folks for going through the psychosocial evaluation process, you can think about as being sort of within the serenity prayer, figuring out the things that you can modify and change them if you can to make people be able to have a successful transplant and do well afterwards, identifying things that you can't change and knowing how to manage them, and being able to figure out what you can and can't modify in the process. By way of background, more cystic fibrosis folks are going through transplant now. This is a little bit outdated, but this trend has continued relative to other recipient populations. And this is sort of there's been an uptick in this over the past decade and a half or so. It used to be that it was a lot of COPD folks going through who had smoked for a long time. Now it's primarily the folks with idiopathic pulmonary fibrosis and cystic fibrosis that are the two big sort of subgroups going through the transplant process. In addition, one of the things that has come up for folks doing research in this area is that many of the recipients are either older, in the case of folks with pulmonary fibrosis, or more medically complex in the case of cystic fibrosis. So folks, whether being transplanted from the hospital or, with more comorbidities and more background medical stuff. So this has been something where the psychosocial evaluation has been made a little bit more complex by people being more complex coming into the transplant process. That said, I should say from the very beginning, CF folks going through transplant tend to be kind of the rock stars of lung transplant recipients. They tend to do the best afterwards. They tend to have the biggest bumps in quality of life. They tend to have the longest survival. And many of the statistics you will hear that are usually outdated from how people do after the transplant are typically applied to everyone who goes through transplant. And that includes a lot of people who don't do nearly as well as the cystic fibrosis folks who do better than any other subgroup. So there's a number of different medical assessments that people go through in the transplant process. You don't need to look at this in any detail. I'm just showing you there can be a bunch of different things people will go through over a course of a few days. Typically, they only see a medical psychologist or a social worker once. And a lot of times you'll come in to see somebody kind of like in an office like this at Duke and meet with we'll typically meet with the patient and their caregiving team. So like their spouse, their mom, their dad, their whoever it happens to kind of be, who's going to be looking after them after the transplant. And you do an evaluation of kind of their mental health and mental health history, substance use history, their behavioral compliance. So how well they can manage their medications and keep up with the medical stuff that's going to go on after the transplant, diabetes management, exercise, diet, that kind of stuff. And all this is in the service of helping them to be able to be successful after the transplant, which is mostly keeping up with the complex medical regimen and attending appointments afterwards. So for folks going through the transplant, typically they are on immunosuppression medications to tamp down their chances of rejection, and oftentimes are on steroids, at least at the beginning, right after the transplant, or for flare-ups or bouts of rejection, and which can do things like enhancing your mood, making your sleep worse, stuff like that. So these are all the things we're kind of trying to anticipate and help people to navigate. A lot of what I'm going to talk about in terms of the areas we typically assess in terms of psychosocial functioning came from this 2017 paper that was a psychosocial kind of consensus guidelines paper that was led by Mary Amanda Dew, who's like one of the primary people in cardiothoracic transplant research and is fantastic. So she kind of led this multidisciplinary team where we came up with guidelines for what we should be assessing, how we should be assessing this, kind of how the process should go. When I think about what we're looking at in the transplant process and how this kind of all fits together, I will usually tell people about the biopsychosocial model. So if you think about how decompensated somebody is coming into the transplant, so how sick they are, how much oxygen they're on, how limited they are functionally, that is very much related to things like anxiety, how depressed they are, how are they thinking about the future and their control over their current situation. Obviously, this is also going to be related to their caregiving team, the folks who are giving them support and how well that's going. And ultimately, a lot of this comes down to what the person is doing. How are they coping with things? If someone is feeling worse because they're more decompensated, are they just like not even wanting to think about the possibility of needing a transplant, and they're just avoiding that thought as much as they can? Or you have somebody where kind of like they don't feel good, but they can tolerate that. They have greater experiential acceptance. They can feel bad and know that it is in their long-term interests to keep going through this process and kind of keep on marching, even though it doesn't feel great at the time. Or do you have somebody where maybe they would usually be a little bit avoidant, but their caregiver is going to keep them going through the process and do whatever they need to do to get to the other side? So I usually think about these things as having a biological, psychological, and social piece. And ultimately, this all comes down to coping processes. What's the person doing? How is this working for them? And are they doing what they need to do to get where they need to go? The most recent ISHLT evaluation for lung transplant was just published just actually a few months ago. And it was Lillian, Christian, and myself were the two psychologists who were on the team. Lily is also fantastic. She's down at the Medical University of South Carolina. And just to tell you a little bit about what we talked about in this document, going back to the initial frame that I gave you, psychosocial data and the reason we evaluate this stuff is a little different than the medical data that you get. It's not like, someone's HbA1c or, their pulmonary pressures. Psych data is more probabilistic by nature. So the idea that someone's going to be non-adherent is you're kind of always trying to gauge someone's risk of not taking their pills afterwards. In the long run, how well someone can keep up with their medications and take care of themselves on their own is the biggest predictor of how well they're going to do when you look at them 5 years, 10 years, 15 years later. And at the same time, even though our psychological data are decently good and pretty predictive, in some cases more predictive than medical data, they're still probabilistic. They are not a biological variable. They are behavioral data. So when these recommendations that we did, one of the things we emphasized was that teams kind of ultimately need to use their discretion, and that none of these factors I'm going to mention should be taken individually. None of them on their own should be taken individually and kind of out of context of the other variables that we're kind of looking at. The other thing was we just emphasized in this most recent consensus document the importance of kind of some guiding principles, that we're doing this for utility, for the the maximum net benefit for everybody we're evaluating, and then also for the ethical principle of justice, to make sure that basically we are thinking about the benefits and burdens within the system and how we are going to be allocating organs in the right way to make sure we're doing this in the best service of everyone. And that there's respect for persons in the sense that some people will go through this and choose for personal reasons, not that they don't want to do the transplant, which is fine and is ultimately at their discretion to choose to do so. So there are some absolute contraindications in this document that I'll just go through briefly. One is just if the person just is of clear mind and they just don't want to do this. If they don't want to be evaluated or are accepting the transplant, it's totally their choice. They're not going to be forced to go through the process. Folks who are older and have a progressive neurodegenerative process like Alzheimer's disease, Parkinson's disease, that kind of thing, usually are not going to benefit quite as much in terms of quality of life boost or survival. And so that's generally considered an absolute contraindication. And then repeated episodes of non-adherence without any evidence of improvement. So someone has not been able to keep up with their medications, missed appointments, not done what they're supposed to do over and over and over again, and there's no evidence they've tried to correct it in any way. One really important caveat is that if you are a younger person or were a younger person at any point, particularly a young male, you may know that younger people, and particularly young males, are not as good at keeping up with these kinds of things because they don't tend to think about the future as well as they do when they get older and they're an adult. So for people in the peds population, this is all dependent on kind of where they are developmentally, and with some recognition that it's much more normative in that age group for this to be an issue, and that it will probably get better over time. And so you have to take that into consideration when you're thinking about folks going through this. And the other one is just sort of active, like ongoing substance use. Like the person comes in and they're still smoking. They may be able to get transplanted in 6 months, but they can't get transplanted right then if they're actively using at the time they're coming in. Other risk factors with higher risk but are not absolute contraindications. Psychological, psychiatric factors that interfere with adherence. So things like someone is really depressed and they're not doing anything to kind of optimize that, and it actually is impacting their adherence. If someone's depressed, but they are very adherent to their medications, that's ultimately the most important thing. Can they do what they need to do to get through the transplant? Things like anxiety, depression are really most important in that they get in the way of doing a target behavior, if that makes sense. So obviously, people being depressed or anxious is important to try to help them with regardless. But in terms of evaluating them for the transplant, it's really most important in terms of can they do what they need to do. An unreliable or unstable caregiving plan, and lack of understanding about the disease process or like the transplant process, even though they've been taught the information multiple times. So for whatever reason, someone that just kind of can't seem to acquire the knowledge base that they need to be able to work with medications and the team, that's also a consideration. And then folks who are overweight, underweight, or more limited in their functional capacity. Other more minor risk factors, diabetes that's poorly controlled, edible marijuana use is that kind of rough consideration. And then again, sort of other kind of biobehavioral risks that are potentially modifiable. Just to flesh these out a little bit more, cognitive impairment, generally, where we think about that as a big exclusion is things like Alzheimer's disease, where it's expected to get worse and worse over time, and the surgery is not going to help with it. Milder cognitive impairments are much more common. About a third of people coming in across all transplant groups, especially when they're sicker, tend to have some level of impairment that tends to be related to the degree of hypoxia. For some of these folks, it gets better. For some, it gets worse. For some, it's very stable. So it's less worrisome because it's not expected to kind of get progressively worse. And it is relatively common, particularly right before the transplant. Things like anxiety and depression, again, kind of are most relevant in that if they are impacting your behavioral compliance. So in particular, we worry about this if you have someone where kind of like they're refractory to treatment or there's something else going on where it just kind of lingers on as an issue. But things like using psychotropics, not a big deal. As long as people are able to kind of keep up with their adherence, that's really the most important thing. Similar for anxiety, folks who are more anxious sometimes are actually the most compliant people because they are more worried about what's going to happen to them in the future. So that's actually usually not a huge issue. It's really more through avoidant behaviors. People who are anxious or have history of things like trauma and stuff, if that is causing them to avoid going to appointments or avoid taking medications, that's where it really gets trickier in terms of them being successful with transplant. The other thing I'm going to talk about just briefly is I was one of the members of the cystic fibrosis kind of guidelines for transplant evaluation and referral a few years ago. And just to tell you a little bit about kind of what we ended up doing through this, there's a few recommendations that we had that ultimately tended to triangulate around getting people information about transplant earlier, if it seemed like it might come up down the road, giving them the correct kinds of information so they knew what to expect afterwards, and making sure that we addressed any transition issues between their primary treating team and the transplant team as best we could. Make sure I've got this kind of in the wrong order. But as part of what I did through this initiative, we did a small focus group of folks who were either had received a transplant or were caregivers of folks who'd gone through a transplant. As a wiser man than myself has once said, Ted Lasso, that all people are different people. So I don't want any people to think that this is going to apply uniformly across everybody. This definitely won't. This is kind of just a preliminary try at kind of getting some themes of stuff that comes up and is more unique for folks with CF going through this process. And there's several things that jumped out. One was that oftentimes folks were not presented with information about transplant until it was sort of in a crisis where they were declining. A lot of times they were presented with information that was really in aggregate across all transplant patients instead of folks with CF who tend to do the best. And interestingly, there were a lot of people who experienced this with some degree of stigma or with a bad baggage about the need for a transplant, where there was stigma about kind of that they might have failed, that they didn't take care of themselves well enough. Whereas for many people, this was just the course of the disease, where they had effectively managed for a long time, getting worse to the point that they needed a transplant. So even though it was a medical need, it was perceived as a psychological failure. And so this is one theme that came up that doesn't tend to come up as often for folks like with IPF or other disease processes. I'm going to skip these because I'm going to run over my time. Just to give you an idea of some of the things that came out here, some sort of quotes related to the different areas that we looked at. I think that you guys should be able to pause these and go back and kind of look at them. But for many people, it was this idea that they'd fight really hard to get to the transplant, and then their perception of them needing a transplant was really kind of enmeshed or kind of overlay with their medical and sort of psychological factors, where in reality, this was more sort of a treatment that works very well if you need to do it for a medical need. Just to finish up, to me, a lot of these things could be viewed within the frame of the social cognitive theory, where if you give people better expectations, that's not just based on their past experiences. If you give people, if other people see folks that are like them going through the process and being successful, And if people feel like they have control over what they are experiencing, they will tend to be more engaged, more confident, and have better outcomes. So a lot of the recommendations that we made were kind of framed through this lens of addressing expectations, having social models where you can, and all that's going to increase people's feelings of mastery over the process and get them more engaged, get them where they need to go. The last thing I'll just kind of say is that the way I think about how all these things fit together, all the risk factors we're kind of mentioning, is they ultimately come down to people's ability to regulate themselves towards effective behaviors. So people's, things like depression, anxiety, cognitive function are all relevant through their ability to have flexible behaviors to get them where they need to go. And social support is a big buffer against that. For some folks with CF, you can have people who tend to actually being on the over-controlled side, where they're really good with managing certain medications. It's just that at certain points when they need to let go to go through the process, the transplant process itself, that's where it can be more difficult. Whereas with other folks who have not had to be as highly compliant over their life course, they may be more poorly organized, and you're doing a lot of kind of get them more to be more under control, whereas they come in kind of not being so compliant and organized. All right, that's it. Thank you very much. And I look forward to getting questions from folks towards the end.
Hi, everyone. Thank you so much for letting me take part in this symposium. My name is Roger Samuels. I am a clinical fellow with a special interest in lung transplantation and cystic fibrosis at the Johns Hopkins University School of Medicine. And I'm going to share with you today some of our recent work, our group's work, relevant to the psychosocial assessment in CF and lung transplantation. We're really honored to have been supported in funding by two separate foundation grants from the CFF at the fellow level, which is my only disclosure for this talk. So I'm hopeful that this talk builds on perhaps some of the ideas that were suggested in Dr. Smith's talk from earlier, in that we as clinicians in CF and lung transplantation are now sort of talking more pragmatically about psychosocial risk in a way that perhaps we weren't in years past. In the same way that guidelines incorporate things like FEV1 and opportunistic infection in a very kind of protocolized way, now the major societies are incorporating language specifically in reference to psychosocial risk. The International Society of Heart and Lung Transplantation in 2018 revised their guidelines to include specific language relevant to transplantation about psychosocial risk. The CFF Foundation, the other CF relevant societies have also been talking about psychosocial risk. And the reason that we're talking about this now and thinking about it more pragmatically in our lung transplant referrals is that we know that it matters. We have data to suggest that things like adherence, social support, mental health, substance use, these have clinical impact that's measurable. Survival, opportunistic infection, disease-specific quality of life, these have all been things to have been observed to be linked with these kinds of psychosocial risks. And so identifying these and addressing them earlier prior to transplant is increasingly important. So I mentioned again, these major societies have guidelines now, and hopefully we've heard about some of those in the last talk. But a big part of our research idea was to identify the fact that while there are evolving guidelines speaking to the need to look at psychosocial risk, a lot of that is still up to some interpretation, and that we wanted to learn more about how centers across the country really are operationalizing these kinds of recommendations, and that's what I'm going to talk about today. So in the broadest sense, our goal through this study was to basically just in light of all of these new transplant and CF recommendations relevant to psychosocial risk, talk to people, talk to all of you and many of your centers to just hear about how you do it. And this basically amounted to what we consider a mixed methods framework, so a number of both qualitative and quantitative approaches to just hearing how different centers interpret and incorporate psychosocial risk into their CF lung transplant referrals and candidacy discussions. And so really, these were our kind of objectives of this kind of a project, was understanding the processes related to psychosocial risk and how these risks are integrated into both the referral and candidacy of our persons with CF. If there was a psychosocial risk identified, how centers work with the patient to remediate those problems. And then even how we as clinicians talk to each other, both to the patient and to other clinicians about psychosocial risk for the purposes of these referrals and transplant discussions. So this is just a little bit about our study's design. The largest component of the study was a series of semi-structured interviews that took place over the last 2 years between clinicians. But then we also had an associated survey. We were talking to physicians, to nurse coordinators, mental health providers, social workers, all at transplant centers. And these are experienced providers. We were targeting specifically a curated group of practitioners that had experience with CF lung transplant referrals in the past. And on the right, you see just a little bit about our protocol. There was an oral consent involved, as well as a recorded interview that was based on a script of semi-structured questions, and then coded subsequently in a process called thematic analysis, which is a way to more systematically and rigorously evaluate something like a qualitative interview. Again, our first step in addressing what was a pretty complex topic was just to get a basic understanding of the sort of processes and workflows in the transplant community. And this kind of approach, this interview-based and semi-structured approach, allowed us to do that and was attempt to be hypothesis generating. So this slide is an example of an interview prompt that would have been used by our interviewers. Can you tell me about a definite no? Meaning a patient that was otherwise clinically indicated for transplant consideration, but was not ultimately listed due to primarily a psychosocial concern. And then that would be followed up after the response by certain probes, such as, did this decision follow an opportunity by the patient to remediate their psychosocial risk? Why or why not? Just to give you an example. And again, there were slightly different templates for transplant and cystic fibrosis providers, but this was an idea of one of the interview prompts, and there would have been 30 to 40 prompts per each template. Interviews lasted about 45 minutes to an hour each on average. And here's a little bit about our respondents. So in total, we spoke in depth to 24 experts in the field between 2019 and now, including throughout the global pandemic when clinical interests were all over the place, and we were very grateful to still get some feedback. These folks represented 11 tertiary centers, both in the US and Canada, and with 24 experts on a pretty narrow topic, we were very fortunate that represents just under 1,200 minutes total of recorded audio. And there's also a good diversity of specialty that were represented in our interviews. So we had 11 physicians, 7 social workers, 3 transplant or CF nurse coordinators, 3 mental health professionals, a slight predominance of transplant over CF dedicated providers, so 19 transplant specialists and 5 CF specialists. And then we had a ratio of 15 to 9 females to males. So as I've tried to outline as well, we really asked a lot of things in these interviews. We asked about kind of all of the major components of the psychosocial assessment and really how the literature talks about psychosocial risk, talking about adherence, mental health, substance use, and social support. Really at just trying to get a sense for how centers across the country operationalize these guidelines relevant to the psychosocial assessment and how they think about these domains. However, as you might imagine, practices and screening and benchmarks are similar in some areas, different in some areas. But interestingly, the reason that I've highlighted social support here is that as our interviewing went on, that topic and that domain really did rise to the top, I think, as one of our most provocative domains, for which there was a lot of very strong opinions, but also very different opinions depending on the center and different practices. So I think that presenting data relevant to that particular domain is relevant for the purposes of this talk, because it just illustrates how centers do it differently and how we can learn from each other, I think, in considering psychosocial risk. And you might imagine that both in social support and in other areas, we could easily identify, I think, a lot of vulnerabilities, things like subjectivity, provider disagreement, whether providers think that things are relative contraindications, absolute contraindications, whether socioeconomic disparities can play into how we identify any of these risks or how we consider them in a, for example, a lung transplant listing decision. But again, for the purposes of this talk, I'll dive in further detail and present some data on social support, because it's a fantastic, I think, example illustrating some of these points. So we listened to these interviews, and through our coding, as many of you know, the idea is to pull out of a range of responses common ideas, common themes. And so as I'm talking through these results and these excerpts from our respondents, I'm going to divide the commentary into kind of 3 broader topics, the first of which is this notion of who the ideal caregiver is. We were very interested in asking respondents to tell us about, who the ideal caregiver is, both what they do, what their relationship to the patient is, and what a little bit about them. And so that's where I'll start in talking about our responses. And this is what our respondents told us, effectively, that in identifying the ideal caregiver, we had to make some commentary about what their relationship is to the patient. Many respondents commented specifically to the stability and health of that relationship. And then many respondents appropriately were interested in identifying the risk factors of the caregivers themselves, as well as whether they had competing demands that would prevent them from helping a lung transplant recipient do what they needed to do. There was different opinions on how many ideal caregivers there should be, so that's part of our analysis. And the last topic would be considered how engaged the caregiver was, and I'll define that loosely as alignment and motivation to participate in the clinical care, both in visits and in the outpatient setting. This is how our respondents kind of broke down their thought process for the ideal caregiver. So let's talk first about how our respondents talked about their framework for thinking about the social support's relationship to the patient. I have, and I will continue to present a lot of exemplar quotes, not all of which I'll have time to read on the purposes of the recording, but feel free to pause and read along. I'll say that in aggregate, family members were strongly preferred over friends and paid caregivers. Really, a lot of respondents, like in the second quote here, kind of question the reliability of paid caregivers. And this third quote I think was really interesting. So really the notion of quality over quantity. So sometimes it still gives us pause, even if the patient has pulled together a network of 15 friends, that these aren't necessarily people that are linked to you by heredity or blood or marriage. These are the kind of folks that end up going through transplant, and then one by one, the social support dwindles because they really don't have a connection that requires them by blood or by marriage to stick around. So that was a really interesting quote that I think, again, reflects the sentiment of many providers across centers. Next is what our respondents thought of in terms of the quantity of social support, or the quantity of, I would call them caregivers. So this slide here shows 3 quotes from 3 experts at 3 excellent centers with 3 very different opinions on this topic. So the first quote reflects, I would say, probably the majority of our respondents, saying there needs to be one primary caregiver and one secondary caregiver, but that's not universal. So the second quote, I think, has said that usually if it's at least one good person, we're happy. And the third quote even went as far as to say, hey, if we have 3 to 4 to 5 people on our rotation, that's fine too. So not all of the centers thought the same way in terms of the quantity of people involved, as you can see here. So our providers have commented on the relationship that the caregiver should have with the patient. They've commented on the quantity of caregivers that we should have in total. But then many of our respondents commented specifically also about the stability and health of that relationship between patient and caregiver, acknowledging that there's many stressors involved in caregiving. This notion of caregiver burnout, we talk more and more about it in the literature. The second quote, I've seen plenty of relationships break up after transplant, whether it's husband and wife or parents and kids. Nothing is for sure, as you know. Just really acknowledging that we should be looking critically, not just at who the person is and how many of them there are, but how stable that relationship is. That was an interesting point brought up by a number of respondents. And let's not forget that caregivers are people too, and they have flaws and they have psychosocial risk of their own. So, an important theme that came up in talking to our respondents was identifying the risk factors of the caregivers themselves. And what are the implications of really assessing even the healthcare or the medical comorbidities, as well as psychosocial comorbidities of someone, for whom really the medical team is not their team, not their doctor. And then also very different opinions about how influential these risk factors should be. So I'll guide you to these first 2 quotes. Participant 18 says, if the caregivers smoke, that's a deal breaker for us. Whereas participant 16 says, families might smoke inside the house. You have to tell them you can't smoke in the house anymore. You have to stay outside for 5 minutes after you're done with your cigarette, but otherwise it's okay. So 2 very different opinions on whether a caregiver can smoke or not, again, by 2 really excellent centers and 2 subject matter experts. So still a lot of interpretation, depending on which center you come across. Many of our respondents acknowledge the fact that even if you have a close family member who's engaged to the team and you have maybe even two of them, if they have competing demands, it might not always work out. And so many respondents talked specifically about whether caregivers had small children or a full-time job or were financially independent. And so I'll leave you with some quotes here to that effect, acknowledging the fact that, we might propose that some of these competing demands are subject to disparities, if really what we're invoking is that all social support has to be financially independent people. So here's a few quotes to that effect. And lastly, as we're talking about the ideal caregiver, a lot of our respondents time and time again brought up the notion of caregivers being engaged. We want a social support network that cares, that is motivated to learn, that is showing up to clinic and has a positive interaction with the caregiving team. And so a lot of the quotes reflected that sentiment. Unfortunately, may also potentially be vulnerable to some subjectivity. The second quote I think is interesting. I look at how the social support presents themselves. If I have someone that seems to have poor coping skills, they may not be the best caregiver. But if they're able to come up with a plan, demonstrate that they're reliable, they have clean mental health, and be a caregiver, then I'll keep them in mind. So a big factor of the patient's candidacy for lung transplant is not just their adjustment and engagement, but also that of their team, of their social support. Really interesting. Okay, so now our respondents have helped us identify the ideal caregiver. Who are they? What's their relationship to the patient? How many of them should there be? And let's say we've come up with, two financially independent, non-smoker blood relatives with a stable relationship to the patient and who are super, super engaged to the care team. Now what? What are we really asking of those people in a 24-hour day? And that's the subject of our next series of questions. So here they are, in the words of our respondents. Here's the list of things that we'd like our caregivers to do. So many responded that, they should help the patient get to their scheduled appointments. That seems very reasonable. Help to keep medications organized. That was a very common response as well. Also very reasonable. Then also helping out with vital sign checks. And because it's a lung transplant, spirometry at home. That's another set of skills, but okay. Being available to call 911 and bring the patient to the hospital. So speaking to emergency response and responding to a potentially critically ill patient in a very vulnerable time in those weeks and months after transplant. So okay, that's on there. Manage drains, manage wound vacs. Sure, okay. Person's had a major surgery. That seems reasonable. Giving the person IVs at home. Right. Our patients are on medications. Some of them are on IV medications. Some of them are on IV antibiotics. We need somebody who's engaged and knows how to help with those things. Many respondents said that they need to be there 24 hours, right? They have to themselves be familiar with the signs and symptoms of rejection. That came out. So, okay, now we're really sort of racking up the list of tasks that we're asking of our caregivers. Be able to get them to clinic in the same day or bring them to the hospital in the middle of the night or on the weekends. So now that they have to be available, a lot. To boot, they have to be compassionate and they have to be emotionally stable. And a lot of our respondents said that they have to emotionally support the patient too. That seems reasonable, but now we're really starting to get into a lot of tasks that we've asked of our caregiving team. And then this quote I really loved. They can, of course, go to the bathroom or run or grab a coffee or stuff, but otherwise they really need to be sleeping in the same either hotel room or house and kind of with the patient all the time. So that's just to really hit home the fact that caregiving is demanding in a lung transplant patient, and we really do ask a lot of these folks. So in aggregate, I think we tried to consolidate a lot of these opinions into just the general 4 topics that I've shown here in our coding, which is to say that the tasks should involve some component of emotional support, tangible or logistical support, even as far as requiring things like a driver's license to get patients back to and from appointments. Some understanding of the medical plan and some comment on a caregiver's ability to respond to emergencies. These were the common themes that came up in these tasks. And then finally, just to sort of round out how our respondents contextualize and operationalize some components of the psychosocial assessment. Again, just social support is all we're talking about here. There's a few other considerations that came up as well, which I'll highlight. I think many respondents reflected the sentiment that social support and caregiving might be different in CF population than it is in other diseases of the lung. But as you might read here, if you pause the commentary, Some of these opinions were very different depending on provider as to whether either persons with CF were more or less autonomous with respect to their medical care. So you can read some really interesting, I think, opinions of how different transplant centers thought about the CF population in these quotes here. Next, let's not forget that transplant centers are often referral centers. So patients are coming from far distances to get there, relocating for the purposes of their medical care. And so a lot of respondents spoke very thoughtfully about how they consider social support when not just the patient, but the caregivers are also asked to relocate, and some of the interesting challenges that arise in that setting, where even people who may have adequate caregivers are in a bad situation because those caregivers are not in a close proximity. So here's a few quotes to that effect. So in concluding this talk, and again, talking about how centers operationalize these new guidelines in reference to the psychosocial assessment, specifically looking at social support, we ask a lot from our social support for our patients. We ask the caregivers to be a lot in terms of their relationship with the patient. We ask them to do a lot once the transplant happens. But unfortunately, there still really is a lot of subjectivity and variability across centers in how we do this and what we ask of them. So I think what we've learned is that probably we still have a lot to develop. And a lot of research and novel ways to develop to support patients and their caregivers when being the ideal caregiver, quote unquote, is not always possible. So I'd like to acknowledge a few of our collaborators here, but otherwise really looking forward to this ongoing discussion in this symposium, and have a few selected references on the following slide. Thank you all.
Hi, I'm Rebecca Hayes from University of Wisconsin, and I'll be talking a bit about how the transplant path can be rocky for some patients and interventions that both social workers and psychologists on the CF team and social workers and psychologists on the transplant team can try to smooth out that path and improve positive adjustment. And I miss all of you guys. I look forward to seeing you in person another time. I have no relationships to disclose related to this presentation. In terms of learning objectives, I hope that we can cover today. First, I want to improve understanding of clinical themes in transplant readiness and adjustment. I'm so lucky to follow the two really high quality presentations before me. And so I'm just going to sort of build on that in terms of actual content and thinking about case scenarios with patients. I hope we can build some clinical skills in navigating the tensions inherent to the transplant process. And what I mean by that is the tension between someone's healthy desire for autonomy and the need for a transplant support plan, or an evolving understanding of self-care patterns, and maybe carrying some old reputations with the hospital as a whole, and balancing the need for pain management with folks as their disease progresses with narcotics rules for transplant candidacy. So those are some of the tensions that I think can come up with folks frequently. And I want to build clinical skills to support patient candidacy and positive adaptation. And finally, I want to be a cheerleader to develop partnering between CF psychosocial providers, transplant social work, and people with CF to support a smooth transplant path. So I've got a few kind of premises to start with. First, I want to suggest that quality of life is generally positive for people with CF after transplant. And there was a nice review piece in the Journal of Thoracic Disease a couple of years ago looking at the benefit of lung transplant on quality of life based on underlying disease. And I wanted to highlight where CF falls on this graph. I don't expect you to dive through all this data in this presentation, but I do encourage you to look at the article. As you see, people with CF on the SF12 PCS score have the most significant gains after transplant, and similarly have the most significant gains on the MCS score as well. So the hope is that people after transplant who have CF get not only survivability advantage, but also much better quality of life than continuing with disease progression. But I also want to acknowledge that the transplant path is fraught and it's confusing. And anything that we can do to create a better more transparent process, but also a process that supports the tensions of navigating needing a transplant and having survived CF for as long as folks did to get to that point. And of course, the CF community has highlighted this as well in recent years, and you're all familiar with the consensus guideline process to define better what CF programs can do to support people with advanced CF lung disease, as well as folks after lung transplant referral. But it does continue to be a problem in terms of referral process and access. And so, this paper is a few years old now, but in that analysis, 35% of potentially eligible patients had not been referred. In terms of my talk, the things that are relevant with that are that predictors included Medicaid insurance, which we all know can be a marker of poverty as well as disability, lower educational attainment, which means that a complicated transplant path may be a little bit more difficult to navigate, and then Burkholderia. But a more recent paper also highlighted these disparities again, and I wanted to talk a little bit about that as well. So this is from a 2020 paper out of Cleveland Clinic, as well as the SRTR and the CFF. And again, I'm not expecting you to take a look, a deep dive in this data right now. But in terms of some of these red lines, so the bigger the red line, the bigger the disparity in access, right? So to me, the things that are most relevant here are BIPOC had much reduced access to transplantation. And then single people or people for whom marital status was unknown also had a really significant gap in access to transplantation. And part of that I want to acknowledge is that the transplant support needs that are required both for candidacy and to cope well with the immediate aftermath of transplant run counter to what we regard as positive CF adaptation. So when someone has truly integrated positive self-care into a positive self-schema and is managing the really complex CF care regimen essentially on their own and is proud of the capacity to do that, having declining lung function and needing to lay out a support plan for a period of time when they'll be, very, very ill and unable to manage their activities of daily living, is going to be very triggering for a lot of patients. And this is a composite case. It could be any number of cases that I've worked with over the years. But in this case, a single middle-aged man who's justifiably proud of his autonomy and his independent self-care and has pretty limited contact with his family, that has not been a central part of his understanding of how he protects his health. That's going to be very difficult for him, particularly given the emotionally heavy nature of facing transplantation, the need for transplantation. And in this article that Patrick Smith was the first author on, that was a really nice qualitative analysis of what the lung transplant referral guidelines can mean, and then what can be easy or hard about the transplant process. One patient pullout quote was that it felt like defeat to need a transplant. And I think that's a theme that comes up for a lot of people, but I think it's particularly difficult for those who are really solo in their cares. And so, I think that raises two concerns for patients. I mean, the first is in order to even get to the transplant candidacy mark, they're going to have a really robust transplant support plan. And second, during that initial recovery phase, and for those of us that have worked with people in that initial recovery phase after transplant, it can be scary and overwhelming to be in a fair amount of pain and be pretty debilitated, and at the same time suddenly having to learn a whole new vocabulary in terms of what markers of health are and routines in terms of self-care. So having that level of independence in general throughout CF has stood this gentleman well. But in terms of getting ready for transplant, he's really going to be faced with having to ask for more help. And so, I think that when you look at the literature about what that looks like in terms of adjustment to life after transplant, this is reflected again in the literature that initial hospital stay can feel overwhelming, and that the recovery can be slower than anybody wanted. So how can we support folks who are at risk of these kinds of difficulties? I think first, setting expectations early in terms of recovery plan supports is helpful because it allows the patient to take more charge of what a support plan could look like when they're feeling well enough to organize that and to find that. I think that in addition, many transplant teams, I think, want the support plan to be as clean and simple as possible. And in their ideal model, that can often just sort of default to a spouse or an adult kid, right? Which is going to be the case for many of their transplant candidates. But it is not necessarily going to be the case for, autonomous middle-aged folks with CF who may not have had kids. And so part of my work in collaborating with the transplant team at University of Wisconsin has been to support, and they've been really helpful about this in terms of thinking outside the box about what constitutes an adequate support plan. And so in this particular composite case, that might have meant a variety of people were going to serve a variety of needs, and that would then help the patient still feel like the quarterback in his own life. I think that this is where the CF Peer Connect can also make a huge difference, because that can reinforce the need for the support plan, and that it isn't just sort of a bureaucratic thing required by the transplant team, and can also reduce that feeling of emotional isolation, valuing the autonomy. So speaking with somebody who's been there can be really helpful. And then again, I think the clinical emphasis for cases in this scenario needs to be to reinforce competence, autonomy, ability to learn and adapt. And so to talk about transplant support planning as being just another task that they can do to help foster both transplant candidacy and positive adjustment. So the second case scenario I want to talk a little bit about is when engagement and self-care has been a work in progress. And so my case example here, again, a composite, is a 27-year-old single woman. And she has gotten care at the CF Center since birth. This is a center where the transplant center is housed in the same place, right? And so during her earlier life, in her late teens and early 20s, as is common for the life stage, right, she really struggled with adherence. She struggled with daily self-cares. And she, checked out of the hospital AMA a fair amount, or she had kind of unrealistic expectations about what could be accomplished in a hospitalization. She really had a hard time. And since then, I think she's really matured a lot and has taken on many aspects of self-care in really inspiring ways. So transplant path challenges. First, her medical record is going to be dotted with a history of non-adherence. Now, I guess I would suggest that we all, think about how we're documenting work around engagement and adherence, and continue to document from a strengths-based perspective, which we're probably better at now than we were 15 years ago, but also to be really clear about noting improvement and maturation and change over time. So be sure that's documented as well in the medical record as the struggles with adherence. The other piece that I think is challenging for folks with CF in particular, with transplant teams, is that transplant teams who are working with folks who have a variety of different diseases causing their lungs to fail may have a binary definition of adherence that doesn't necessarily match well with CF practice norms. So if we can move forward with the idea that CF treatment is incredibly cumbersome, and it would be extraordinarily rare for anyone to be 100% adherent to all of the treatment recommendations for somebody with CF. That is going to be a hard standard to keep up in a transplant candidacy process that asks for 100% adherence, and when treatment recommendations are much simpler for people who have other diseases. And I think it is also true that other diseases are likely to hit end-stage lung disease later in life, when patients are more likely to have matured into middle age mellowness and typical higher rates of adherence. So part of the process, I think, in working with folks who have a history of struggling with non-adherence, particularly in late teenage and early adult years, is to truly partner with the transplant team about adherence expectations on their end, but also adherence practices on the CF center end, and to help the patient identify their strengths in their self-care. And what I mean by that is, in the CF care model, the norm is to foster a long-term relationship that includes pretty honest disclosure, so that goals and priorities can be identified in terms of improving and strengthening health. And I think the transplant process is more based on an evaluation model, where, at least on paper, there may be right and wrong answers, right? So I think that for folks that have moved forward in very measurable ways in terms of their self-care, and are at a point where they are achieving good self-care for CF, it's important to be able to have a shared dialogue between the transplant center, the CF center, and the patient about where the patient is at now and what would be needed in order to achieve transplant candidacy. I think part of that, too, is transplant centers building nuance around the care of young adults who may have a more recent history of struggling with self-care than someone who's 40 or 50. And, I think that the differences in style can, again, be exemplified by this paper from Clinical Transplantation, in which one patient noted that the transplant team are super experts at making sure your lungs are working, but they may be less compassionate than the CF team around the side effects of transplant medications. And I think it's more that, I think that's a lovely quote, and it exemplifies a little bit about what I was talking about in terms of the strength of the CF team relationship over time with patients, and the partnered care model, and the transplant model, which may be a little bit more hands-off and a little bit more didactic. So some of this is going to also include expectation setting with the patient. So intervention approaches should include documenting maturation and adherence improvements, and empowering patients to be able to recognize and articulate these changes too. So to support them in being proud of the path that they've taken. Collaborate with the transplant team about CF adherence patterns and expectations, and as well as educate about CF treatment burdens. And then acknowledge differences in care models, because there can often be a tension between the history of a trusting partnership with the CF team and wanting to say the right thing to pass at a transplant evaluation appointment. And the third case scenario I want to talk a little bit is challenges related to pain management for folks with declining lung function. So in this case scenario, again, a composite case, 24-year-old single trans woman, chronically ill across several organ systems. And as her health status declines, her pain gets worse. So the transplant path challenge here is fairly clear. Narcotics use is a contraindication to candidacy, right? But the opposing issue is that as her health status declines, complementary medicine is less tenable for the patient. And she becomes increasingly more urgent in her experience of pain. And this can be heartbreaking to try to balance with patients. So thoughts in terms of interventions with this scenario, I think it's important to align recommendations between the CF and transplant teams about usage, be very transparent about that, clear, consistent, simple. In some circumstances, transplant candidacy can be a motivator to support narcotics use reduction and to try alternative methods. In turn, the transplant path, in other words, the need to change usage patterns to become a candidate for transplant, can sometimes be a way to get prioritized access to pain management treatment or substance use treatment for systems that are overloaded. I want to acknowledge here that these are the cases, at least for me, that sit in my gut the deepest, because I don't know that there's necessarily been a great answer. So I've worked with a couple of patients who continued to struggle with pain and narcotics use and were never able to reduce that use enough to meet transplant candidacy guidelines. And I've worked with others who really were able to dig in and access treatment that was also specialized to their particular pain burdens and engage in that deeply enough to be able to reach transplant candidacy. I think that their pain continued to be difficult to manage after transplant. So I'm not pretending that this ended up being a super smooth road, but they did achieve transplant candidacy and certainly got what I would describe, and I think most people would describe, a positive outcome after transplant. They just continued to be hard folks to care for. I want to thank the people with CF who teach me about perseverance, adaptation, and teamwork, and Jessica Dotkin, who's the transplant social worker at University of Wisconsin, who's been a great collaborator in thinking through some of these tough cases. Thanks very much.
Hi, I'm Erin Tallarico, Clinical Director of the Advanced Lung Disease Program at the Cystic Fibrosis Foundation. I would like to thank the organizers for inviting me to join you today and to talk a little bit about our CF Foundation Lung Transplant Initiative and some current findings as they relate to psychosocial impacts along the transplant journey. I have no relationships to disclose related to this presentation. Briefly, some goals for today. I just want to go over our advanced lung disease and lung transplant work at the foundation, define advanced CF lung disease, since that's what we'll be talking about throughout the presentation to make sure we're all on the same page. We'll discuss the importance of psychosocial support for people with advanced lung disease, review some psychosocial recommendations from CF Foundation guidelines, and then I will end with a brief presentation of a real-world example of improving psychosocial support for people with CF pursuing lung transplant. So through surveying the community and individual discussions with people with CF and their families, the CF Foundation learned that this community of people really felt they were no longer a part of the CF family once they had a lung transplant. Many felt that they represented failures in CF care and felt abandoned. They urged the CF Foundation to explore this perspective, which we did. And this resulted in lung transplant and advanced lung disease being included in the CF Foundation's long-term strategic plan. So in 2016, our advanced lung disease and lung transplant initiatives came to fruition under the leadership of Drs. Al Farrow and in collaboration with Dr. Joe Paluski at the University of Pittsburgh. And as you see here, our mission statement is to improve the care and long-term outcome of individuals with CF and advanced lung disease, to optimize decision-making and access to lung transplantation, and to ultimately improve outcomes after lung transplant. Some of the things we've been focusing on are guideline development. Our first guideline we published was on lung transplant referral. And this gives CF care teams guidance on when to consider referring an individual for a lung transplant referral and evaluation. Next, we published our advanced CF lung disease guidelines, which give CF care teams specific guidance on how to best manage someone with advanced lung disease. And then we have our models of palliative care, which talk about incorporating palliative care along the lifespan of someone with CF and not just at the end of life. And then we have post-transplant management, which focuses on what is unique to individuals with CF after transplant. And this is aimed at our lung transplant colleagues to help them better manage people with CF after they receive a lung transplant. Facilitating research has also been a huge component of our work. We have built a consortium of CF lung transplant centers that are working together to help find therapies to prevent or treat chronic lung allograft dysfunction. They have helped us to build the infrastructure, including a biorepository and a registry. And this will allow the consortium to study chronic lung allograft dysfunction longitudinally with the power of the numbers of a multi-center consortium. We also are working on risk stratification for advanced CF lung disease by having CF care teams collect specific data related to their advanced lung disease patients in our CF patient registry. We are looking to better identify those with advanced lung disease who may stay stable for a long period of time versus those with advanced lung disease who become sick quickly and ultimately need lung transplant. And lastly, one of the things we've been working on is improving care while nearing a transplant referral. And this has been done through our CF Lung Transplant Learning and Leadership Collaborative, focusing on transplant referral and transition. And some of the major themes that have come out of this collaborative have been relationship building, communication, so within the CF care team and between the CF care team and the lung transplant teams, and then education for care team members about lung transplant, and education for patients about transplant and helping them make better decisions. Next, we'll move on to our definition of advanced CF lung disease. I won't spend a ton of time on this. You can find this in our advanced CF lung disease guidelines, but simply someone with an FEV1 less than 40% predicted when stable, someone referred for a lung transplant evaluation, or if you have one or more of the following characteristics, including needing oxygen at rest during the day, pulmonary hypertension found on an echocardiogram, a 6-minute walk test distance less than 400 meters, etc. So now that we have a common understanding of advanced CF lung disease, we will move on to some psychosocial recommendations. And the first one is found in our advanced CF lung disease guidelines. And it states when individuals with CF meet criteria for advanced lung disease and with subsequent changes in clinical or social status, the CF Foundation recommends a formal care conference involving caregivers and selected team members to develop a plan for ongoing psychosocial support. In adults with CF and advanced disease, caregiver support is associated with fewer physical and emotional symptoms. And additionally, caregiver availability often factors into lung transplant eligibility. And this is based on pre-transplant support being linked to better sustaining one's daily care, as well as post-transplant outcomes found in general transplant, organ transplant populations. And then proactive communication really does allow for better preparedness while approaching complex health issues and decisions. So care teams are encouraged to formally identify support systems for those with advanced CF lung disease, while normalizing the need for support and offering education on caregiver roles during disease progression. Next, we will move on to our referral guidelines and lung transplant psychosocial considerations related to the transplant referral guidelines. So the CF Foundation recommends that the individual's CF care team elicit and address CF-specific psychosocial and physical concerns about lung transplant to help facilitate the transition. So we convened a focus group of people with CF as part of our referral guideline development. And numerous psychosocial, physical, and care-related concerns emerged as being particularly important among these individuals. Some examples are increased complexity of care, the potential for decentralization of care, so essentially meaning leaving your CF care center that you've been with your entire life and having to transition to an entirely new care team with the lung transplant program. They mentioned worsening impairments in quality of life at a young age, the potential loss of their CF identity once transplanted, concerns regarding family planning, relationship issues, and education career paths, all influencing their approach to the transplant process. Next, lung transplant referral guidelines. Again, the CF Foundation recommends that modifiable barriers to lung transplant be addressed preemptively to optimize transplant candidacy. And then it goes on to talk about potentially modifiable barriers, such as mental health and psychosocial factors. Certain psychosocial factors may take years of work in order to optimize a candidate for lung transplant. And mental health diagnoses should not prevent access to transplant. However, addressing mental health concerns as proactively as possible can help lead to the best possible outcomes following transplant. And the last psychosocial related recommendation that I'll mention today is one that involves coordination between CF and transplant teams. So the CF Foundation recommends the CF and lung transplant care teams acknowledge and provide support for mental health concerns regarding the referral and evaluation process. Depression and anxiety are common among individuals with CF, and if persistent and not treated adequately, may adversely impact lung transplant outcomes. So this was one of the driving forces behind developing our CF lung transplant transition learning and leadership collaborative. They have truly jumped in and started paving the road for improving the care of those pursuing lung transplant, leading the way in smoother transitions to transplant. And they're starting to take a deeper dive into the psychosocial issues impacting candidacy, such as finances, caregiver support, and accessing resources. So we're going to switch gears now and talk a little bit about our Learning and Leadership Collaborative and some of the findings that have come out of it. And as you can imagine, and probably experienced yourselves as care team members, the transplant transition and referral process can certainly be challenging. We heard this loud and clear from the CF community, as well as the lung transplant community, that it's often a very frustrating process. We know there are a lot of variations and practices, and we wanted to help programs improve the processes involved in lung transplant referrals and transitions from the CF program to the transplant program, and to ultimately foster a model of shared care and responsibility for the patient. And that's what's depicted here in this graphic. You see our patient and family in the center between the CF program and the transplant program. When we started this, there was a real sense of, this is mine and that's yours over there. And it was kind of independent care between the CF program and the transplant program. And what we ended up doing is really fostering a sense of shared responsibility. And so the CF Referring Center and the Lung Transplant Centers have truly come together to become a CF lung transplant transition team. Relationships, communication, and partnerships between these multidisciplinary CF lung transplant teams and individuals with CF is essential before and during after transplant. We started this collaborative in 2017 with 10 academic transplant centers who each partnered with a referring CF program. And I'm proud to say that the network has grown to include over 40 CF programs and close to 20 lung transplant programs at this point. And now we'll talk about the University of Vermont Adult Cystic Fibrosis Program and what they've done to improve the mental health support along the transplant journey. One of their goals was to improve support for their patients' mental health as they go through the transplant process. From the time that they first meet the criteria for advanced lung disease to the time of transplant and beyond. Fear and avoidance of the topic of lung transplant often presents a barrier to discussion and affects the well-being of our patients with advanced lung disease. And so what they did, they realized there was a lack of standardization in their approach to discussing the transplant referral and in how they help their patients prepare for that process. And they were falling short of recognizing and addressing the mental health impacts of lung transplant. So their intervention was to first optimize their approach to mental health screening by tracking patients with advanced CF lung disease, including their last mental health screen, which is pictured here. And they also offered multiple modalities for completion of the anxiety and depression screening using the GAD-7 and the PHQ-9. They offered telephone screenings. They developed electronic completion of surveys using REDCap, and also continued to offer in-person screening by the CF social worker. And some of their results were great. They were able to significantly improve the mental health screening completion rates and have found that these questionnaires really do serve as a good starting point for discussing mental health. The second thing they worked on was developing a transplant education packet, which focused on mental health and how to prepare for the initial transplant visit. This education packet is distributed to appropriate patients as part of their discussions of lung transplant referral, which I'll touch on in the next slide. The flow diagram here shows how their social worker identifies individuals with advanced CF lung disease who will be coming to clinic within the next month. They then review the advanced lung disease spreadsheet that they've put together to confirm if conversations about transplant have started. If conversations have begun and they're ongoing, then they take that time to determine the next topic for discussion. And if they haven't started, then they take that time to come up with a plan for when it's appropriate to start these conversations. And it truly is important to start these discussions about transplant early. This really allows plenty of time for patients and families to learn about lung transplant and alternative options if transplant is something they do not choose to pursue. We want patients to be able to ask questions, identify and address potential modifiable barriers, and find ways to prepare mentally, physically, and emotionally for transplant. And this flow diagram shows their lung transplant education program. So once patients who have advanced lung disease have been identified and have started discussions about transplant, they're provided an education packet and booklet that covers the topics listed here. And you'll note there is emotional and behavioral health specifically called out. There's caregiver support and practical considerations. They talk about healthy behaviors, living with advanced lung disease and lung transplant. They discuss nutrition information, medication, alternatives to lung transplant, and have frequently asked questions. Individuals with CF are given the autonomy over the pace at which these discussions occur, and they are also asked to prioritize the order for discussion. They then move on to discussing individual sections with appropriate providers, whether that is a physician, a nurse coordinator, a social worker, or their nutritionist. And then they are entered into their education tracker. This helps identify what has been discussed and when, and then they also plan for what to discuss next at upcoming clinic visits. Just a special quick thanks to the University of Vermont CF team for allowing me to use their quality improvement work as a real life example. And I hope that some of you can take these ideas home with you and use them in your practice. And then one last thing I wanted to bring up that we've learned through our Learning and Leadership Collaborative that's been extremely impactful is to connect with your colleagues. Really consider getting to know your respective colleague on the lung transplant team where you refer most of your patients. An example of this is having the CF social worker and the transplant social worker come up with a regular communication with each other about mutual patients. This could be through regularly scheduled Zoom calls or phone calls to discuss mutual patients, not only pre-transplant, but even post-transplant. Even something as simple as regular email communications back and forth. And then also consider having a CF team member join the transplant selection committee meeting. Obviously, you would need to discuss this with your transplant program, but a lot of our teams have been able to do this. And it's a great way to be an advocate for your CF patients being discussed at the lung transplant selection committee meeting. And then I just wanted to wrap up with some patient perspectives. And I think this is a great way to close out the session. Many people with CF have strong emotional reactions to the topic of lung transplant, and often they experience a range of emotions, as we see here. These are two quotes from patients who participated in our Learning and Leadership Collaborative. And the first one says, "When my doctor first mentioned transplant, my heart was racing, and I felt like I blacked out the rest of the conversation. I just wanted to get out of that room as fast as I could. I didn't even go back for my next clinic appointment. And I'm pretty sure most of you can relate to this and have had patients that you have seen that have had this similar reaction. I don't think it's too uncommon. And then on the flip side, we have a patient who said, I was so relieved when my doctor brought it up, I cried. I'd been thinking about it, but no one was talking about it. As soon as my doctor brought it up and gave me the folder, I just started reading everything I could. So there's no right way to react or cope with the transplant discussion. And our hope is that CF and transplant teams, that you're there to support people wherever they might be. Thank you.
Good morning, everyone. I am Rebecca Bathon. I am one of the co-chairs for this symposium, and I'd like to introduce my co-chair, Heather Brushwine. We are so thrilled to be hosting you today for this discussion. I am the lung transplant social worker at Barnes Jewish Hospital in St. Louis, Missouri. And as I've heard these speakers, I'm so moved by thinking about all the barriers that my patients have overcome all of these years. I think about people that had to bring campers to our staff lot for their 3 months of housing, or people that raised tens of thousands of dollars for transplant, but couldn't put it in the bank because they would lose their entitlement. So they kept it in a drawer or a mattress. And I think about how our patients have gotten creative and how they've put together caregiver plans. And as our speakers have pointed out, those are all the strengths that they bring to this or bring to us as transplant programs, which we hope to kind of elaborate on through the rest of this discussion. I want to remind everybody to post their questions through Slido. Heather will be monitoring that. We will try to answer as much as possible. But just a first kind of quick introduction of who's with me today. Patrick Smith, who is a clinical psychologist at Duke University Medical Center. Roger Samuels, who is a clinical fellow at Johns Hopkins. Rebecca Hayes, who is multifaceted, currently the mental health coordinator at University of Wisconsin, and many, many years as a transplant social worker, I understand. And then, of course, Ellen Tellerico, who runs all of the transplant initiatives at the CF Foundation. So thank you, everyone, for being here today. I wanted to just, of course, kind of chuckle that the first question that we're going to propose kind of focuses around the hot topic of marijuana, medical marijuana, edible marijuana. So it really asks if there's consensus or what is the red flag around recreational use, whether it be medical, whether it be in states where it's not authorized for medical use, and how that plays into candidacy for transplantation. Patrick and Rebecca, I'd love to hear your thoughts.
Thank you so much, Rebecca. And thanks everyone for being here. I miss you. I miss being able to do the coffee clatch afterwards. And believe me, it is weird to give a talk to yourself on the screen ahead of time. But I really appreciate this question, although I'm a little annoyed with you guys for not doing a softball question first. Not Rebecca and Heather, the crew. So I guess I want to start, and then Patrick is going to offer additional insights as well. I guess I want to start by saying, in our own work, we have to center around, to some degree, what we control and what we can't control. And if you are part of the CF team helping somebody walk through the transplant process, you are unlikely to be able to change a transplant candidacy guideline at the receiving transplant center. You can absolutely foster additional discussion, case consultation, encourage discussion of having that stuff change, but that may not happen in the moment with your client. And so whether or not you agree with the the receiving transplant center's candidacy guideline, part of your job is going to be to help set realistic expectations for the patient about how they're going to reach transplant candidacy. So that's one thing I'm going to say. The other things I'm going to say are about medical marijuana as a moving target that is very site-specific and region-specific. So if you are at a CF center that could potentially refer to different transplant centers, it is possible that those different transplant centers are going to have different policies around transplant candidacy. Specifically where I practice in Madison, Wisconsin, That's about 2.5 hours from Chicago. And so and Wisconsin has different laws around marijuana than Illinois does. And so it is not, out of the line of possibility for folks who are living in Wisconsin to access transplant processes in Chicago as well. Now, I certainly would agree that for my patients that marijuana has been seen as a pretty effective pain treatment strategy for many, and is certainly considered lower risk of harm than opiate use. And I have observed and talked with my transplant center colleagues about how hard it is to assess that use, to sort out whether somebody's eating it or smoking it, to think about dosing. And so I think all of that makes for a very complicated muddle. And I will pass that muddle over to Patrick Smith.
That's great. Thank you.
Yeah, that's a buddy
right.
pass.
That's good. Yeah. So I was just gonna say I think it's a really good question because it comes up so often, and I think the initial question was about whether that constitutes a red flag if somebody was using that, because I think in the past marijuana use kind of did sort of function as a red flag because it was illegal, and so in most places, even if it was kind of okay and understood within the person's background, it was still something that did kind of stand out because of legal things against it. And now it's a much more kind of varied picture because different places have different sort of policies towards marijuana use. So I think the two things that I always encourage people to do are that I don't think you can understand any of these things outside of the context of the patient and kind of what their kind of background history is. I have certainly had people where they have refractory pain kind of conditions, for example, where they have failed a lot of treatments that they've thoughtfully gone through and ended up using that, and that's been successful for them. And to me, that's kind of maybe even kind of a good thing. They've gone through all the other kinds of steps. They've tried things that would be conventionally more available, and this works for them. There are other people where this is the only thing they've tried, and it's because they have sort of avoided other, kinds of approaches for managing whatever it is they're kind of dealing with. In reality, a lot of the reasons that people will use marijuana, so things like anxiety and dyspnea and nausea, it can work well for them. And there are also lots of other treatments that are approved that you could kind of consider. So I think it's the kind of thing where keeping those things in mind, and just keeping in mind that I think, as the person who made the comment kind of mentioned, if you're taking in marijuana, there are components of that will alter your metabolism of tacrolimus, among other kinds of medications. And so if you're going to do it, you have to be very careful and sort of thoughtful about the way you're going to manage that. There's a lot of, anecdotally, this is increasingly coming out and people are publishing about it, but people showing up to the ER because of having almost, very adverse psychotic effects sometimes from being kind of overdosed in a way because they weren't metabolizing things in the way that they were kind of supposed to be. So I just think it's you can't look at any one of these things by themselves and kind of looking at the person's background in particular. But I think that understanding, at least from my perspective, understanding this can serve a useful function, particularly in some subset of patients, and that knowing those other things around that can be really useful in sort of figuring out its role.
Thanks, guys. We've talked a lot about the role of family and caregivers in this transplant process, which we all know is very, very important, if not so much as the patient. Have you guys faced a scenario where maybe the parents, the caregiver, the spouse was pushing transplant a little bit more or significantly more than maybe you judge the patient's interest to be? Patrick, any thoughts on that?
Sure. Yeah, I was just thinking, so certainly I have certainly had people in the past where there was some ambivalence about kind of the need for transplant. And although, again, everybody's sort of different, but if you can imagine, one of the more common scenarios is if you think about when someone is thinking about going through the transplant, it's their first time, and thinking about what that's going to look like, oftentimes they are projecting into the future whatever is sort of, if people are familiar with availability bias. So there's this kind of bias that we all have, which is we anticipate in the future what we already know. So if we're not familiar with things that can kind of happen to us in the future, sometimes how we think about it is not as accurate as it may be. And for some people, it's oftentimes issues of independence. It's issues of having to kind of go through something in the past and feel like I'm a patient again, where I didn't want to kind of have, that kind of, I feel like that's going to change my role in some ways. There's oftentimes ways that people are thinking about the transplant that kind of are apart from the medical need. It's more kind of like this represents something else. There's certainly people who choose not to go through the transplant. I mean, that definitely does happen, but it's oftentimes what I found is more common is people have normative concerns, appropriate concerns about, I'm going to go through this complex medical thing. do I really need to do this? What's this going to mean for things down the road? And so I will usually kind of get a good understanding of someone's understanding of their own prognosis. Usually people don't realize what's going to happen if they don't get the transplant, and that's much worse than what's going to happen with sort of possible short-term difficult, navigating independence and things like that. But then also going through a life-saving treatment usually means something different for different people. There's usually things that people are trying to get back to in their lives that are going to be different for different folks, and sort of understanding what those are and how this fits in can usually give you a lot of insight into kind of what are the barriers and does this make sense for them and how would I navigate them?
I think it's also very, very important to consider who you're interviewing when you do a psychosocial assessment. You're obviously not going to bring a 19-year-old in with mom and dad because you're not going to have the dialogue that you want. I tend to bring patient in first and then family in at the end. Have any of you guys seen things done differently?
I've done it that way sometimes, or also sometimes the opposite of starting with the patient and family and then seeing the patient alone after that. But yes, I think it's definitely important to be speaking with the patient alone.
Rebecca, did you want to add something?
Well, I was going to say, I think you want to take emergent context out of this, I guess. But I do think that meeting with the patient on their own first, at least in my practice, generally has some benefits because you can sort of get at least a baseline of where they're at. And as Patrick says, sometimes additional conversation about what options might mean, and if nothing else, sort of desensitizing to some of this information.
Mm-hmm.
And then ultimately respecting the patient's autonomy, and then, having the space to sit with mom or dad or partner, whoever, and just kind of reinforce that ultimately it's going to be the patient's call.
One thing that's probably worth mentioning too, for what it's worth, I totally agree with what everybody's already said, but I think it's also worth mentioning that sometimes the dynamics between the patient and the family are much more sort of ingrained or long-standing in CF patients than they are in other settings where you're just pulling in somebody to be a caregiver that you just kind of had this thing. And so it's also, there's a lot of opportunity for things to be recapitulated that may have had a kind of a longer and more complex relationship in the past. And so I think it's even more worth having somebody one-on-one, but sometimes seeing that, then sometimes that's part of what I think you can be seeing in these rooms is you're sort of seeing somebody kind of, the independence thing comes out because this was a dynamic they're used to from when they were less independent as a teenager, as an example.
So age is definitely an issue. I hear you saying that. Absolutely. We also have a question that asks, the person who's asking the question is curious about people with CF who decide against transplant and then change their mind at the last minute. How does this generally work out? We might talk like medically where things are, and then add the psychosocial component and how all that comes together. Roger, what are your thoughts?
Everyone, thanks so much for having me. I can comment, I guess, specifically in our work from listening to a lot of you, many of who are in the session listening in on some of the responses that we got. I think one theme that came up over and over again is perhaps related to this is the notion of the emergency referral, in that a person or a team who had not necessarily been going the standard pathway for a lung transplant referral and got very sick. And how in a sick patient or a hospitalized patient, the way we do our work and the way the patient gets informed about moving along the transplant pathway becomes a little bit tougher because they may be incapacitated, they may be very sick, there may be a short window in which all of these different assessments that we're tasked with doing happen. And perhaps that's a good example of where this question is coming from, in that a person might change their opinion very suddenly if they were to become very sick. And then I think all in all, the process becomes a little bit harder, which is why, as Aaron has talked about, as so many of you have talked about, trying to do some preparation early so that we're not in a situation collectively as providers and as patients to have to aggregate a lot of these evaluations in an emergent setting, because they're never, unfortunately, quite as good. I don't know if my colleagues have other commentary.
Yeah, thank you, Roger. I was just going to, the work that Aaron and the CFF are doing to support earlier education around transplant, I hope, is going to result down the line in some culture shift, both in terms of our practices and in terms of people with CF's perception of being provided some transplant education. I think for many of my patients, the transplant discussion was sort of, a marker of the end, and many have likened it to, needing oxygen. That these are end of life markers. And I think that if we can integrate transplant earlier and normalize discussion around transplant earlier in disease process, folks are going to have time to have some of that reaction before it becomes an emergency. And I think we have started to see that in some of our practices at Wisconsin. Although honestly, I think we're still learning what an early referral looks like, because for many of our patients, those early discussions are met with like, really? What do you mean? And even if they contact the transplant center is like, really? Wait, you're fine. So I think figuring out how to have that dialogue and a way to prevent those last minute crises is a work in progress, I think, for our whole community.
Thank you, guys.
Rebecca, I'll add one more thing.
Sure.
And this again will vary by center, as we've been saying, but I think what can also happen is if a patient doesn't feel ready or says no, then the transplant team absolutely does not want somebody moving forward who doesn't want transplant. And so I think if somebody were to come back and say, okay, I have thought about it and now I do feel ready, I imagine like most programs would be like happy to reopen that evaluation, because they do want people who are ready for transplant. And in terms of continuing the education, if the patient has said no to transplant, probably most likely most centers would then stop following that person and not have any interaction with them. So the education could come from the CF team then to keep perhaps bringing up transplant as a conversation or talking about with the patient why they declined. And then if that changes in the future, being ready to support them.
Yeah, I love that point, Heather. Thanks.
Yeah, absolutely. I agree with you. It's not cyclical. It's not something that we go step 1, step 2, step 3. Sometimes we go back to step 2. And I think this ties into our next question about, how do you partner with patients? I think when the lung transplant initiative started, Erin, there was a lot of kind of discovery that programs had patients that probably needed to be referred or started discussion with transplant, and medically were there, but maybe mental health wise or psychosocially weren't even in the process of considering it. What did you see in the initiative as far as what programs we're finding over the last couple of years?
Yeah, thanks, Rebecca. Great question. I think some of the things we've learned from the partnerships between our transplant programs and our CF programs is this happens a lot, right? We know medically this person is ready to rock and roll and they're just not quite there yet. And I'll reiterate again the importance of really looking at this as a journey and not just one conversation, right? When we bring up transplant, oftentimes I think about that quote I ended the presentation with about the patient who just completely blocked everything else out. They didn't hear anything. They heard transplant, and a lot of people think, oh my gosh, I need a transplant tomorrow. Ideally, we want to be having these conversations early enough so that they can continue to receive education and ask questions, have an opportunity to connect with a peer who's been through the process before. And so that hopefully eventually they'll get themselves ready and prepared with the support of their care team and their social support system as well. Personally, from when I worked at Hopkins as a CF coordinator, we were in a position where our transplant team was right there. And so we started doing something called a meet and greet, where the transplant team would have either a coordinator or even one of the physicians join us in CF clinic to purely just introduce themselves, to show their face and ask or answer any questions that the patient or family might have about the transplant process. And it was purely informational. And then after that, we would decide, do you think you're ready to be referred? Is now the right time? And I've seen this throughout our Learning and Leadership Collaborative. A lot of programs have started doing this. And I think in our world of telehealth being a lot easier to access, it's much easier to do this for programs that don't have an integrated transplant team, right? If the program is 3 hours away, you can hop on a Zoom call and have the transplant provider in on these conversations with the CF team, who the patient and family are already very comfortable with. And so I'm hoping that that is something more teams can start integrating into their work to help with bringing patients along in that psychosocial aspect.
I love that with the new guidelines, patients come to see us with this big, broad, coat of armor that says, I don't need a transplant yet, but I'm still here. And you've got such an opportunity to start the discussion to say, okay, here's what things need to look like. And let's work on those. And let's collaborate with your CF social worker, your mental health provider, the dietitian to get you there. Absolutely.
I love that framing, Rebecca. Thanks.
Our next question is surrounding the use of ayahuasca, and forgive me if I'm mispronouncing that, a psychoactive drink that contains DMT as an impairment for lung transplantation. Certainly somebody with more experience in this range can chime in if you would.
I'm but a humble clinical fellow. I can't say that in my brief time I've seen this come up. I think Patrick mentioned specifically to cannabinoids that there's at least two important metabolic enzymes for cannabis and marijuana derivatives that are inhibited by through marijuana use that actually end up cranking up your serum levels of calcineurin inhibitors. And in my quick search about ayahuasca after this question came up, it seems that it too is a pretty potent inhibitor of at least one of these pathways, CYP2D6, and so theoretically you might actually, similarly to a lot of the cannabis products, get high levels of your tacrolimus and other CNIs. So that's something that I don't know much about. I'm not a pharmacologist specifically, but I'm not sure how dose and unique metabolic pathways of this kind of a drug are considered, but that might be one potential adverse effect. I don't know if any of the rest of you have seen this used or dealt with dosing tacro in a person on ayahuasca. I'm not sure, but it's an interesting question.
Yeah.
So the two comments I would have on this is there's not going to be any general practice across the country in terms of transplant candidacy. So that's one thing that's really important to know, is that every transplant center, even for substances that you might think would have universal guidelines, like alcohol use or whatever, and there's going to be varying. So that's number one. Number two, I think this gets back to Patrick's point earlier that context is really important. So if you're talking about a microdose of ayahuasca in the context of psychiatric treatment for bipolar disorder, for example, that might be considered differently than somebody going on really big scale trips on a regular basis with their friends. So, I mean, I think that that's something where the context and the specific transplant center are going to guide the answer.
I think that's right. The only thing I was going to add, I agree with about what Roger and Rebecca were saying, is just that I think one thing that I will oftentimes say to patients, just by way of kind of helping them understand why we have some of these diverse requirements at different centers, is that I think a lot of transplant centers understandably try to control as many things as they can, because there's some inherent uncontrollable factors that go into the transplant process in terms of like, when do you get the match? How good is that going to be? Your immune system is very complicated and can have different reactions. So if there are things that they can eliminate or kind of mitigate risk by you doing something behaviorally to get that out of the way, they usually will try to do that, because all things being equal, that gives them a better shot at being able to give you the best outcome. So I think that for a lot of these things, that's at least one way I've seen some of my, pulmonary and cardiothoracic colleagues refer to as, it's not that it's necessarily about any specific thing by itself. It's just that if this is something that we can do to make this more streamlined, that's going to help us to help make this the best, go as well as it can.
And to second what everyone has been saying about the context too, I think it's also very important to just talk about the the context of that use. And if it's something like, oh, sure, I tried it on a trip 5 years ago with my friends, and I do not regularly use it and don't plan to use it again, would be much different than somebody who is using it on a regular basis. And even if they were using it on a regular basis, I think if, like Patrick was saying, if it's something that can be changed, or if they're willing willing to modify that, I think that all of those are taken into consideration.
Thanks, everyone. Shifting gears just a little bit, and I know this will really be some nice dialogue, and perhaps everybody will want to add a little bit, but the question is around the impact of new modulators in patients who are waiting for transplant. What have we seen as far as those have been on the wait list? Do they come off? Do they improve? And how often is this happening? Erin, maybe you want to start, because I know this has been a big issue in the LLT.
Sure, I'll chime in. The easy answer to this is yes, there are patients being removed from the wait list. Our hunch is that yes, it's probably related to highly effective modulators, most specifically Trikafta. I think we don't have enough data quite yet to really say that for sure. And the next couple of years are going to be extremely important to see what the true impact is of Trikafta on those with advanced CF lung disease. One of the really big important reasons why we are capturing this data now in our registry, and most specifically want to continue to capture the data on those even after they start Trikafta, right? So if they have advanced CF lung disease and then they start Trikafta and their lung function goes up to 60%, that's amazing. We still want to capture their data because that's the cohort that's going to be really, really important to study moving forward. But yes, overall, we have, I would say, in the couple of years leading up to the previous year, so 2018, 2019, we were looking at 250, 260 CF lung transplants. And last year, we were in the 70-some range of CF lung transplants. And when you look at that compared to lung transplants for other diseases, it is drastically decreased. So I don't think we can say it's just because of COVID. Perhaps COVID had some slight impact on that, but I think the answer is that, yeah, Trikafta is definitely having a very positive impact so far on those with advanced CF lung disease.
Yeah, and I bet all of you have a story or two or three. Yeah, I mean, it just makes me smile thinking about it. So we had a patient who was listed for transplant and started on Trikafta and got he gained 20 points in PFT and he gained 20 pounds and he got off the list and now he's, close to getting back to work. So yeah, I mean, I think there's those kind of stories. I think the other story that comes to my mind though, is in the last year, one of our patients who did need to get referred to lung transplant was late middle age, and he just was really bummed that Trikafta didn't come in time for him, And so I think there's that other side of it too, where we have patients kind of grieving what their CF did before the treatment was available.
I was going to just add one other thing, just because I think it's relevant for what we were talking about before, is that, one thing that's happening, or that anecdotally, and I think there's a little bit of research on this that I've seen with Trikafta that happens with a lot of other disease processes, is as treatments kind of get better and you can push the need for more invasive treatments off further, the decline at the end tends to be also more precipitous. So this happens for all kinds of conditions. Like I'm actually in the neuropsychology clinic today. So as people's reserve levels are higher, they can withstand things for longer and then they kind of crash more quickly. So I mention this only because I think that it's been amazing seeing how people have responded to Trikafta and the benefits they've had clinically. And I think for people where you are anticipating that a transplant will likely be something that's at least worth considering at some point in the future, everything we were talking about before about sort of addressing concerns and ambivalence, I think largely still holds, because you're going to have people where you can push this off medically for a while. And then when the need comes up, it is likely that you can have people that are coming in that are declining much faster. Not that happens always, but I think that's generally the situation we try to avoid because of all the complexities that kind of go into it. So I think it's great to have something that's disease stabilizing. It's fantastic. So just trying to keep in mind that for folks where at some point there may be something that's going to be needed down the road, it's good to not let that sort of function to avoid things that you're anticipating down the road, so that you can get people the information they need, in a timely way.
I'll just say we had a comment from an attendee, which is important, where they said they've had at least 2 patients who asked to be on hold themselves due to feeling better. They didn't have a huge improvement in lung function, but just felt better and more stable. So it was the patient's decision to be put on hold. So I think it will come up in both scenarios where the transplant team might be suggesting it, or it could come from the patient.
I was just going to chime back in quickly too, kind of along what Patrick was saying. I think CF transplants are going to look different in the future as well, because as we're able to push it off, we're going to be looking at a different type of transplant in an older population. And so that's definitely something that we are thinking about at this point, and how we will adjust and adapt to that, transplanting an older CF population in the future.
That's a great comment, Erin. Thanks.
I would say now, though, I am thrilled when I see a referral for transplant that's under 50. I kind of get tired of the older people. Okay. There's a question about financial resources for patients and families. And Patrick, I know that you get some funding from the Boomer Esiason Foundation. Do you want to kind of kick off our response in talking a little bit about their program?
It's really a point. I think we've had a lot of people that have done just access sort of different, there's different, foundation resources in particular that are available for folks going through this. I think in my experience, this varies so much just based on the patient's sort of background and their sort of social context that they're in. And we've definitely had people reach out to both CFF and the Boomer Esiason Foundation to kind of see what other kinds of resources they have, because because at a foundation level, they're much more instrumental and organized. And then, there's just a lot of, we can talk more through this if people want to, but I think beyond kind of those is the main things. I think oftentimes, institutional resources kind of vary. Sometimes people are able to kind of modify their approach or the way that they are kind of dealing with barriers that come up because of those. And so I imagine this is probably quite different across different folks who are within different sort of insurance and sort of geographic regions. But I think that just being aware that there are resources to kind of help navigate some of this, and that I always tell patients that one of the more common concerns coming in are things like, sadly about like insurance and being able to kind of cover for things, which I have known like very little about personally. And it's also one of the most common things that people are able to successfully navigate. So usually I just try to reassure people that this is not an unusual concern, and that there are a lot of resources out there. They may look different for what people end up kind of utilizing themselves, but there's a lot of options for people to be able to figure it out if it's medically indicated.
Also offer here, just from our perspective quickly, that in talking to a lot of again, centers throughout the US and Canada, some centers really did highlight this as a gap, saying that, that this is a particularly vulnerable period in the post-transplant window financially for patients and families. And so a lot of them had protocols for fundraising and to help patients with fundraising, and even had certain benchmarks, although I'll say that was not necessarily uniform. I think it surprised us how often things like fundraising and a financial kind of safety net came into play, and even in the pre-transplant setting, and how centers kind of uniquely helped their patients with that.
I agree with you, Roger. And I think the other kind of interesting piece is it's a huge worry for patients and families. And it's not something that they bring up to the nurse and to the physician. It's a head bob. Yeah, I will take care of this. And then when people like myself as a social worker sit down and we start talking truly dollars and cents, I want to be very clear and forward and put it into perspective for them. They may think, I can take family medical leave, or my caregiver can be off work for 3 months, but not realize that that's unpaid leave for the most part. So directing them to Boomer Esiason's grant program, to CODA, to Help Hope Live, to organizations that can really help them put together a nice plan for fundraising, and just tackling and tapping into any resource that's in the community or at the institution is really key. And empowering patients start the process early, I think, is an important message.
Yeah, Rebecca, I was just going to jump in and add to that and say, CF has the Compass program, which are case managers that are available. And that's pre-transplant and post-transplant, right? If you have CF, Compass is available to you. And I'm not sure that everyone realizes that even after transplant, Compass can help. And they have resources, like you just mentioned, and direct people to different ways to fundraise. And I also think, again, going back to the importance of bringing this up, talking about it early and often. This is one of the big reasons why. It gives people time to plan, so that it's not a shock, a month before transplant that you have to have X amount of dollars in order to be listed. And again, really building that relationship between the CF team and the transplant team. Those social workers are crucial. And those, two social workers being able to talk to each other and navigate this together with the patient and the family is extremely beneficial.
You guys, I think I'm going to be a little bit ornery here, and I apologize. We'll just kind of go. So I absolutely agree that talking with folks about this early is really important. I also agree that there's a lot of resources, especially for people with CF, as opposed to other diseases that can cause lung failure, to offset what I would think of as incidental expenses. But I do think that there are some of our patients who are really socially and financially vulnerable and isolated, and for whom fundraising is not necessarily a very realistic ask. And what I mean is that if you're somebody who works for a big employer or is in a union or goes to church or has a big family, fundraising is a fantastic option to talk about and think about. And I think that social workers will be able to engage folks. And I think this gets back to folks who've adjusted well to chronic disease don't want to have, a fundraiser for themselves. They're used to helping do fundraisers for other people. And so being the one to accept the help is a whole process. And I think that that's important in terms of the transplant path and transplant process. That said, if you've got somebody with really vulnerable social supports who's been out of the workforce for a long time and isn't really connected with their community, it's almost it starts to feel delusional to talk with them about a fundraiser when they can't even, when they even struggle to find a ride to the hospital. So I guess to me, I do want to sort of acknowledge that. And then I think part of our job is to sit with our patients in the loneliness of that, if that's the situation, and then sort of begin to think, because that's where the incredibly wonderful grants available through Burma Esiason Foundation and other nonprofits are not going to cut it. They're not going to cut covering lodging for a couple of months when somebody lives 6 hours from the transplant center, right? I'm from the Midwest, so everybody's like spread out. So I think that's just me being a Grinch. I'm sorry, but I'm going to throw that out there as a complicating factor in our work.
That makes sense. Go ahead,
agree
Roger.
100%. Go ahead. I was going to say that, I think we agreed 100%, at least from our perspective, analyzing some of our responses, whereas it was interesting to have fundraising brought up as a potential pre-transplant or peri-transplant measure. I felt perhaps a little bit more uneasy when it was listed as perhaps a criteria, like there was a particular benchmark that must be achieved prior to proceeding. I think that 100% would be vulnerable to disparities, just as you've identified 100%.
I was just going to add, I think that one of the things I think about was, because I agree with what everybody's already said, when we were doing the CF, transition to transplant, and we were going through some of the guidelines, going into that, really one of the framing reasons for doing it was that most of the evidence seemed to suggest there's a lot of people who at least ostensibly would have met criteria for transplant. I mean, it's hard to know because they were never evaluated, but they never got kind of referred over. And so one of the primary ideas, and when Kathy Ramos and everybody in the group, when we were talking about it, when we were trying to set up the framing of it, was really, you'd almost expect that you're going to have more of those kinds of conversations potentially, because you're hopefully getting more people who at least have the opportunity to be able to address some of these things to get to transplant if it's possible. And so the flip side of that is you're getting more people that are coming in. There probably are going to be some people that are in just really difficult social situations and may not be able to make some of those sort of changes. But implicit within that is that, in the scheme of things, hopefully you're going to at least have given people sort of a better shot at doing it. Like the world is not perfect and there are going to be barriers that we can't always overcome, but at least people are kind of aware of it. So I totally agree. And when we were going through the guidelines, part of what I was thinking, to your point, Rebecca, was we'll probably end up having more of those conversations, which will not necessarily be sort of comfortable. And that's probably the right thing. I'd rather be there than not having those conversations at all. So totally agreed.
Completely agree, Patrick and Roger. Thanks.
Yeah, great points to raise and to kind of present both sides of the picture. And I appreciate that from all of the panel members. Roger, I'm still so intrigued about your findings with the caregiver piece in what you presented today. Tell us what else kind of resonated or stuck out or surprised you in the work that you've done so far with interviewing transplant team members.
Thanks so much. Yeah, it was a really fascinating process. I also, as a newer transplant clinician myself, just learning in general about my practices and how I will go on to think about, this process and this journey for our patients. But I mean, we tried to frame our interviews agnostically in that we didn't necessarily narrow in specifically on caregivers. That came up organically through talking to people. We took and said, Dr. Du and Patrick's paper, these consensus ISHLT, recommendations, and asked about everything. We asked about mental health. We asked about substance use. We asked about, adherence, expecting that those areas might generate a lot of debate as well. But instead, it was really this notion of caregivers and how we define them, and how do we, fix the problem of a patient who may not have, or how do we define this quote, unreliable, unstable caregiving plan that was talked about as such a concern. I think that was definitely surprising, and then just learning really how different centers operationalize that process. We have we're hoping to continue that work. It's with some of the responses that have been generated from this project to go on a step further in a larger cohort of centers to further understand how we across the nation and the region that define caregiving support. I'll give the plug to our upcoming project to that effect, which will involve many of you who are listening in on this session, hopefully. But yeah, that was really, I think, interesting. And I mean, we just finished talking about fundraising. We didn't have any specific questions at the beginning of the study to talk about financial support or fundraising, but that topic also came up a lot in our responses, and that was kind of, again, organically generated by our participants, which was again very, very polarizing for the reasons that we talked about.
Certainly an eye-opener for me. So thank you for elaborating on that. We've got a few minutes left. And before we wrap up, I think it's a great opportunity for Erin to kind of share what the foundation is doing to support this. You talked about Compass, but kind of share with our audience what else is out there.
Absolutely. So specifically related to some education, we put together, and thank you to Sarah, who already popped this in the chat, a handout that shows the transplant journey. And so, like I mentioned in my talk, I think, a lot of times patients hear transplant mentioned and they jump automatically to, oh my gosh, I need a transplant next week, when really trying to help people understand that it is a journey, and it's going to start with the discussion and then perhaps a referral, and giving everyone the opportunity to be referred and to meet the transplant team. And have the opportunity to learn from them and ask questions, and realizing that referral does not necessarily equal evaluation, right? You may be referred, you may not be ready for an evaluation yet, and kind of lining out what that looks like. And then what happens after evaluation at the transplant discussion meeting, and what does it mean to be listed with UNOS? So the transplant journey handout, I think, is a really good starting point to have these conversations. We are also we have funded a few projects that are looking at what are called right now decision aids or decision tools about transplant, and looking at the risks and benefits. They have a bit of an education component to them. They have stories from people who have gone through transplant. They have stories from people who decided to decline transplant, which I think is extremely powerful for our community to be able to access those. So those are all still in the design, research, testing phase, but we're hoping that soon, in the next year or so, we'll have these education resources available for community members to use in partnership with their care teams to really have these conversations together and to help make the best decisions possible for themselves and their family members.
Thank you, Erin. And we have 2 minutes left, so we'll wrap up rather than starting another question. But thank you to all of the speakers and to the audience for your questions as well. This is such an important part of CF care, and I think how to improve the transplant experience and the coordination between the CF centers and the teams is really important to all of us. So thank you to all of the speakers. I just put in the question box my email. So for people who didn't see the previous question about the slides, if you're interested in the slides, shoot me an email and I will get them sent out to you. And yes, I just want to thank everybody for joining us today and for having this discussion.